Okay. Well, good afternoon, everyone, and welcome back to our Women's Health Lunch and Learn series sponsored by Rowan Medicine. I'm Dr. Joanne Kaiser-Smith. I'm an internist and geriatrician in the Department of Medicine here at Rowan, SOM. And I'm pleased to be your host today. We have two very happy to be here women who are going to be speaking about topics that we feel are very important to women of all ages. And with this being Cancer Awareness Month, we thought we would have a speaker about that. And then to keep in touch with the gynecological theme of the day, we've got Dr. Schmutz attacking it from the mental health perspective. So I'm going to introduce our first speaker, Dr. Rachel Schmutz, and she'll tell us about herself, what she does, and then take it away, Rachel, with your fine topic.
Thank you so much. Hello, everyone. Thank you for coming. My name is Rachel Schmutz. I'm the Vice Chair of Education for the Department of Psychiatry at Rowan. And my clinical specialty is in women's mental health. The subspecialty within psychiatry goes by many names. One of them is reproductive psychiatry. Another subset of that is perinatal mental health. But within the scope of my practice, I specialize also in essentially any psychiatric or behavioral disturbances that happen as a result of or coincidental with female life cycle events. So women who suffer mood disturbances, anxiety, or any other psychiatric manifestations in relation to menstruation, infertility, menopause, pregnancy, menstrual irregularity, and the such. So I'm glad to be here and speak with you today about one of those topics and premenstrual mental health. So I have a couple of slides that's just going to kind of keep me on track so I don't go overboard here. And to talk a little bit about what is premenstrual mental health and mental illness and how can we address it. So I'll just get started. So during the couple of minutes that I'm going to be talking, I'm actually going to just define what premenstrual is because it's kind of a vague term and I think a lot of different people use it differently. I'm going to talk about what kind of mental issues could occur around the premenstrual period, what's normal and what's not normal, and then what can be done about it if something is abnormal. So just very quickly, this is a very medical slide, but just to give you an understanding of what premenstrual is, this is a visual depiction of what occurs hormonally and also, sort of within the uterine ovarian tissues during the menstrual cycle. When we're talking about premenstrual, we're talking about everything actually that occurs after ovulation during a regular 28 to 30 day cycle, which many women are regular. Many are not, but many are. And midway through that cycle, the egg is released from the ovary, and that's called ovulation. And then there's a whole bunch of hormonal changes that you can see occurring throughout that time. And after ovulation, the time between that and when the period onsets is called the luteal phase. And anything that happens during the luteal phase, we can consider premenstrual. So some women will say, oh, I'm PMSing, I have premenstrual symptoms a couple of days before the period. But some women actually suffer with premenstrual symptoms for half the month, for 2 weeks out of their 4-week cycle. So it could be anywhere between 1 day and 14 days where people are having, premenstrual symptoms. Common complaints about that people feel are uncomfortable during the premenstrual time are cramping, usually lower abdominal cramping or even stomach cramping and upper abdominal cramping related to GI disturbance that you can have during that time, bloating and weight gain, carbohydrate craving, the sort of stereotypical that, I want chocolate, but it's also a real hormonal phenomenon, lethargy, and also mood disturbance. So it could be due to any one of these three things, and depending on the severity and how it affects your life. So there's the typical sort of PMS that we use as a verb sometime, and I used before, where we say I'm PMSing, which is an excuse or an explanation for some of the symptoms. And then there's something called premenstrual dysphoric disorder, which is actually a diagnosable mental illness that has a little bit different than what we consider PMS. And then if you already suffer from mental illness in some way, shape, or form, whether or not it's well controlled, a lot of patients will say that they have premenstrual dysphoric disorder, but really it's just a worsening of their symptoms during the premenstrual period time. So it could be sort of any one of these things that people suffer from that could affect how they feel before they get their period. So premenstrual syndrome actually occurs in up to 80% of menstruating people. And so it's actually considered a relatively normal phenomenon, and I'll tell you why in a moment. The symptoms are similar to what I described below, maybe a little bit more, or having more than one. In addition to all the what we call somatic symptoms or the bodily symptoms, you can also have mood disturbance, particularly and usually a little bit of irritability or anxiety. The symptoms for PMS tend to be mild to moderate, but they're usually not debilitating. So people can maintain their functioning in social, occupational, other areas. It may be more difficult to function in those particular areas, but they can still function. And that if nobody, if close people around them might, sense that they're a little bit testy, but they're not, the people who are experiencing PMS are not necessarily dropping the ball at work or coming in late. They're able to get there, do what they have to do. It's not as fun as usual, but they can do it. Some people tend to have one predominant symptom or several of the mild symptoms. So a lot of people may suffer from just severe cramping or not severe, mild to moderate cramping and no other symptoms, or they'll have a little bit of everything. They're all mild, but uncomfortable when put together. Usually these symptoms can occur with every menstrual cycle, regular or irregular. And symptoms may or may not resolve when you get your period. So sometimes people feel a little worse when they get their period, especially if they're heavy bleeders. So this is premenstrual, but can also be menstrual. And I think that's important to note. And again, this is not considered an abnormal state. Some people may take some over-the-counter or herbal supplements to sort of manage the symptoms and help them move through. But once it passes and once they get their period and their period is over, they feel fine. So this is normal. This is a normal physiologic state. And what's abnormal is actually what we call premenstrual dysphoric disorder. So this is a definable mental illness that's in the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition. So for any of you out there who are not familiar with that, this is our big book of psychiatry. That's what I tell people. It's essentially diagnostic guidelines on how we diagnose mental illness. It's not perfect, but it is what I use it as a guide. So according to this book, the DSM-5, symptoms must be present in the majority of menstrual cycles. So symptoms may not occur actually every cycle. Symptoms must be present in the final week before the period. So we're not talking about 1 to 2 days of symptomatology. It's at least a week, sometimes 2 full weeks in the luteal phase, which is that premenstrual period. Improvement of their symptoms is dramatic and really, really almost as soon as they have their periods, they feel 1,000 times better. They would prefer to have their periods than to be premenstrual. And in the beginning of their cycle, they have absolutely no symptoms whatsoever. And then within the symptoms that are present, one of them has to be a mood symptom and one of them has to be a behavioral or a somatic symptom or a body symptom. And I'm going to talk more about that on the next page. So doctors can make a diagnosis based on what the patients report, but it's usually confirmed by mood charting, which is something that the patients or you have to do in order to help the doctor diagnose this. And I'll talk a little more about that too. The predominant mood symptom in premenstrual dysphoric disorder by far, and I like bolded, italicized, underlined, and starred, is irritability. More than 90% of people present with severe irritability in the premenstrual period. They also may have some depressed mood, low mood swings, but they are just super edgy and reactive and angry. That is the predominant mood symptom. And then the body and behavior symptoms usually are similar to what we see with depression, or some overlap with PMS. Can also have the severe physical symptoms. So there might be decreased interest or joy, which we call anhedonia, low concentration, low energy state, usually increased or decreased sleep. I often see increased sleep because people are so tired, feeling overwhelmed, but they can also have those physical symptoms that I described in PMS, and they can be really severe in PMDD. And here are some of just examples of that. What's really distinct about PMDD compared to PMS is that this is actually quite uncommon. It's very severe and causes major dysfunction. These are people that are calling out of work 3 to 4 times out of the month, usually in those last 2 weeks of their cycle. People who get into arguments and have interpersonal conflict during this time. So only about 2 to 6% of menstruating people actually fulfill this diagnosis, especially when mood charting is done. But then there's the flaw in the DSM, which says you have to have 5 symptoms. Well, what if you have 4 symptoms and you feel awful? That's called subclinical or subthreshold diagnoses. And if we consider those people who have major dysfunctioning, but that may not meet all of the criteria, we're looking at maybe up to 35% of people. So it may be more common than we think based on the sort of the rigidity of our diagnoses. It's distinct and cyclical. So there's no other mental illness that has a predictability as good as PMDD. We know that when people have this, that at a certain time during the month, they're going to have symptoms. And at a certain time during the month, the symptoms are going to go away dramatically. Other than something called seasonal affective disorder, we really don't have any other mental illness that is this predictable. Give me 1 sec. I lost my screen for a second. It doesn't like me. My computer does this all the time. Okay. This PMDD can also start at the first menstrual cycle. So we're looking at young teenagers or preteens who can actually have some of these symptoms, and it actually gets worse with age. So most people don't realize that they might have this until they're in their 30s. They can have 20 years of progressively worsening symptoms. And the delay to diagnosis also happens because, like I said, it may not happen with every period. So sometimes it happens with the majority of periods. So if a person goes 3 months without major PMDD symptoms, they might think it went away and then it comes back, and then that ends up just delaying when they seek care. And then anytime a person is not ovulating or not having a period, of course, the symptoms will resolve. There's multiple proposed theories as to why one person may have this and one person may not have this. A lot of it might be genetic. So if there's a family history of this in the family, then that person has a higher chance of getting this. There's a theory that's surrounding this one hormone called allopregnanolone, which is a metabolite of progesterone, and that patients with PMDD don't have sufficient increases and decreases in allopregnanolone, which acts in the brain as sort of a sedative or a calming agent, not dissimilar at all to, say, Xanax or Ativan. And then again, it's a genetic predisposition. We do understand that essentially there's an abnormal sensitivity to normal hormone fluctuations. So I can take progesterone and estrogen levels of women with PMDD, and they're going to be completely normal. It's not that the hormones themselves are abnormal. It's how sensitive people are to the fluctuations from month to month to the hormone changes. Risk factors include any type of trauma, either mental, sexual, physical, in the past or present, a history of depression, a family history, and any history of any other mental illness surrounding female life cycle events. So people who have PMDD and have children tend to have a history of perinatal depression or other mood disturbance around the postpartum period. And then anyone, like I said, anyone with any other female life cycle events that have mood disturbance accordingly can have PMDD. I think the one thing that's really, if you're going to take one thing away, is that PMDD causes major functional impairment. And like I said before, they cannot push through the symptoms. The symptoms are severe and debilitating. And then, if a lot of people suffer from depression, anxiety, and other mental illness, and sometimes they think that they have PMDD, but there is a separate entity where you just have worsening of your underlying mental illness during, the premenstrual period. Symptoms, the way to differentiate this from the other premenstrual disorders is that symptoms are usually present all month and they just get worse during the premenstrual period. And then when the underlying or the main sort of disorder is treated, it gets better throughout the month, not just premenstrually. And you can see this not only with mental disorders, but also with other medical disorders. And it's commonly seen with women or menstruating people who suffer from diabetes, anemia, or endometriosis. And then if symptoms remain despite maximal treatment or optimal treatment of what other medical or mental illness is happening, and there's still debilitating symptoms in the premenstrual period, then maybe they do have PMDD as well. But sometimes we have to treat and monitor and watch before we can make that diagnosis. So the next question in our objectives earlier was, what can I do about it? What can be done if we have PMDD? So lifestyle modification, this is what we call a biopsychosocial illness. There's a biological component, there's psychological components, and there's social components. And we try to target treatment at all of those things. But biological is actually the mainstay of treatment because it is a very hormonally mediated disorder. So, but there is some evidence to support some good lifestyle changes that have general benefits, not just for premenstrual health, but for health in general. Obviously, cardiovascular exercise, healthy diet with low inflammatory foods, plenty of water, more complex carbohydrates versus sugars, simple sugars, and breads and unrefined or refined flour. Reduction in caffeine and alcohol is counterintuitive in some ways because you think we need caffeine to stay awake and maybe alcohol to chill out, but honestly, they tend to worsen the irritability and tension. So we advise people to reduce that. And then there is some evidence, not great evidence, but some evidence to support that calcium supplements and chasteberry, which can be gotten over the counter, can help with some of the bloating and some of the body symptoms that occur during the premenstrual period. And this goes for PMDD, but can also be helpful for sort of standard PMS. And there's not a mixed evidence on magnesium, but some people swear by it. It's sedating, and so it can help with the sleep disturbances that occur premenstrually as well, but also has a calming effect. The mainstay of treatment are antidepressant medications, and particularly the selective serotonin reuptake inhibitors. And for PMDD in particular, they're actually prescribed very differently than they are for other disorders where they're first line, like major depressive disorder and generalized anxiety disorder, where they're actually dosed very, very low and sometimes only taken during the premenstrual time. They can also be dosed with the onset of symptoms, or they can be taken every day, but they tend to work really well and really robustly and pretty much right away for people who have PMDD. So you would have to talk with your doctor about which, sort of dosing schedule is right for you, but they tend to be very effective. And then also contraceptives, oral contraceptives or hormonal or non-hormonal contraceptives. So premenstrual disorder can actually be worsened by most of the estrogen progesterone combination pills that are on the market, but the non-combo pills or any birth control that contains drospirenone or any of the Yaz or Yaz related products, another newer product is called Slind, which is very similar, actually works very differently for birth control than the estrogen progesterone typical oral birth control pills, and has a diuretic effect and has a calming effect. So people who switch to these with PMDD tend to do better on the drospirenone containing birth controls. And then non-hormonal intrauterine devices are very effective means of birth control. However, they can make cramping and bleeding during the period worse. So people may have mitigation of their mood symptoms leading up to the periods, but the periods might be worse. So there's a little bit of a trade-off. Of course, there's also psychotherapy. Again, this is a biopsychosocial illness, so this will target the psychological and social components. Cognitive behavioral therapy is usually the answer for most things in psychiatry, but there's actually in development a new mindfulness-based cognitive therapy, which is being used specifically with patients for PMS and PMDD. It seems to be very successful, but right now we're not quite sure if it's good enough to be used on its own without the other interventions, and that future studies will give us more answers about that. But it seems to be helpful for mild to moderate symptoms, and it uses the approaches in cognitive behavioral therapy, which very, very succinctly explores the relationships between people's thoughts, feelings, and behaviors, and tries to modify one or more of these things and see how it affects the other things in the triangle. So it uses those standard principles and also adds in other mindfulness-based practices like meditation, grounding, progressive muscle relaxation, walking, yoga, body scanning, and relaxation breathing. And there are apps for this. There's an app for everything, but there's apps for this as well, where you can do mindfulness and CBT actually on your own. It doesn't replace the in-person or virtual with a therapist, but it certainly can be helpful. If you ever wanted to look up any other resources, the mecca of women's mental health is Mass General. They have a women's mental health program and center. It's both a clinical and a research program, and they have really wonderful literature on their website for the public and also for providers at womensmentalhealth.org. And there's also an International Association of Premenstrual Disorders. So there are certainly some very good resources out there on more information. And that is the end of my talk. Thank you very much.
Thank you, Rachel. You really brought to the forefront a lot of the things people may have and think that they're just not, that they're alone in all this. And certainly you've made us realize that any one of us watching right now may have some or all of these symptoms. We're going to hold questions for Rachel till the end of the presentation. And then we're going to hear from our second speaker, Dr. Hosen, who is going to talk about breast cancer, but I'll let her introduce herself and the specifics of her topic.
Hi, everyone. My name is Dr. Susanna Hussein. I'm an assistant professor in the Department of Family Medicine at Rowan School of Osteopathic Medicine. I'm also core faculty in the family medicine residency. And so I, as a family doctor, really care about prevention. Like, this is like my bread and butter. And I do have a emerging women's health practice in my office. So I'm really also want to bring awareness to some of these things today through this talk, especially because it's Breast Cancer Awareness Month. So there are a few medications mentioned in this, and I don't have anything to do with them. So I just wanted to let you guys know that. Things I really would like everyone to take away today are just to recognize things that you can change and things that are just inherent to you for risk for breast cancer. Some lifestyle modifications that have had observational data that can help prevent breast cancer, and then also understand some options for risk assessment and for prevention of developing breast cancer. So that's what I'm going to talk about. But breast cancer, these are statistics from New Jersey. So there were over 8,000 cases of breast cancer in the last year in the state of New Jersey, and just over 1,000 deaths. So it is a very common, it's the second leading cause of cancer-related death for women in New Jersey, the first most being lung cancer. So it's just really important for us to stay vigilant on this, because even though we have made great strides, we can still do better. New Jersey is actually very good at getting mammograms. So over 72% of people in New Jersey receive their mammogram, but we can still do better. So, and because most of the people that are not receiving like their screening mammograms do have some health disparities. So it's really important for us to stay vigilant. I just want to bring a little bit of awareness about where breast cancer comes from. It's usually arises from two major sources. One is in the most common being the ducts, which are where you lactate through to bring the milk through the nipple. And then the other are through the lobes or the glands within the breast tissue. If you ever have heard about DCIS, LCIS, those are abbreviations for ductal carcinoma in situ and lobular carcinoma in situ. Those are precancerous states for breast cancer, and usually the most common thing that we find on after people have an abnormality on mammography and then have a biopsy. Breast cancer, like most cancers, progress through stages. So the most, the least stage being those precancerous states, like I said, the lobular carcinoma in situ or ductal carcinoma in situ, pressing to like actual mass or tumor, to moving into the lymph nodes, which you can see the little red going from the mass into the lymph tissue, and then more invasive in a different location in the body, which would be advanced cancer or metastatic cancer. The way that the breast tissue is, it's very close to the lymph node drainage in the armpit. And so it's just that's why when we do breast exams, we always check up into the armpit for women. So going into some of these risk factors, there's definitely things inherent to what makes you you and your history that you just can't change. But there are things that observationally we have seen that can potentially put people at higher risk for breast cancer. And those things are usually things that we can adjust slightly. So I'm going to go through the things that we can't change first. And the first is that we all get older, unfortunately, and we do see the risk of breast cancer going up after the age of 55. And so that is something that, as we age, we do see more and more breast cancer. Genetic mutations, things that are inherited through the family or just happen because they happen, those things, of course, we can't change. Having family members with breast cancer, something we can't change at all. And then, some particular breast conditions, one of which is like the dense breast tissue. I'm going to talk about that just a little bit more. Starting your periods early, going through menopause late, just having more exposure to hormones over your lifetime can put you at a slightly higher risk of having breast cancer. Having any radiation done to your chest, and then being exposed to a certain chemical that we don't really get exposed to anymore, that happened more in the mid 1900s, that exposure to the DES. So that doesn't happen as much anymore, but just something to be aware of. So on all mammograms now, they do report the density of breast tissue, and that is because we have seen over time that having the denser breast tissue does, one, slightly put people at a little bit higher risk of breast cancer, but the thing that it does more is it makes it harder for us to detect it. So if you can see in the picture I have under the mammogram picture under fatty breast tissue, this breast, you can see like through it really well. There's nothing really obscuring the image. Mammograms are a series of x-rays. So the better the x-ray is able to go through the tissue, the darker it will be. And so you can see it's very black on the outside, and that's because the x-ray went straight through that air. But in the breast tissue itself, when it picks something up, it appears brighter or lighter. And that can be something that the radiologist will be able to tell us as the physician, like, hey, there's something going on here. There is something that we need to look more into. As you go into the denser breast tissue, you can see that it's much like all these white patches that it's really hard to see through. And that just makes it a little bit more difficult to detect breast cancer with mammograms. You might be asking, well, why don't I get something else? We have all sorts of different imaging tests. And for certain people, getting additional imaging is recommended, especially for those who have a first degree relative. So mom, sister, somebody that's one person removed from you within your immediate family. We do recommend to get additional imaging after discussing this with your physician, usually an MRI of the breast. However, we don't recommend this routinely for everyone, just because the more imaging that we do, the more we pick up things that may not even be cancer. So we don't usually recommend this for everyone because it usually leads to a lot more biopsies of things that aren't cancer. All right. So the more modifiable things that we can help to reduce in our lives to help us, reduce our overall risk of breast cancer are not drinking as much alcohol. Sometimes, like being overweight or obese increases the amount of hormones that we're exposed to over time. So that can put people a little bit higher risk of breast cancer, especially postmenopausally. Not being physically active, not having children, not breastfeeding, and using hormonal birth control. I put an asterisk by the hormonal birth control because I don't want people to stop using birth control. I think birth control is great, but for certain people, if there is a high risk of breast cancer, using certain estrogens and progesterones can put people at be exposed to more hormones over time. The one thing to know about it is, though, after you stop using birth control, usually after a few years, your risk returns back down. So as long as there's no personal history of breast cancer or pre-cancer, using hormonal birth control is usually very safe. There were some theories about things that could cause breast cancer, like using certain antiperspirants, bras, having a history of miscarriages. All of these have been disproven as causes of breast cancer. So please don't worry about any of these in terms of increasing your risk. So what can you do? The things that usually most doctors recommend to help keep everyone healthy are things that you can also do to help reduce your risk of breast cancer. So getting regular physical activity, keeping a healthy weight, limiting alcohol content, staying away from smoking, and then avoiding use of postmenopausal hormone therapy. Again, with this, the trials that we looked at with most of the data that we have about risk factors for postmenopausal hormone therapy were from the Women's Health Initiative, and with that, it was all observational data, and most of the things that we saw more risk factors with this were for one, like blood clots and stroke, but also with sometimes it does, like being exposed to estrogen in the postmenopausal period can increase risk of breast cancer. But we've kind of swung the other way, where we've started to use hormone therapy after menopause a little bit more now, but in very selected patients. And so we go through usually all the risks and benefits of using these type of therapies if you're going through like a really hard time with menopause. So when you're at the doctor's office and you are there for your physical, or you're there for your annual GYN appointment, some of the things that your doctor might talk to you about are like your personal breast cancer risk. And so one of the most common tools that we use is the breast cancer risk assessment tool. It has basically, we put in several different features about you into the calculator to determine what your risk of developing an invasive breast cancer would be over the next 5 years. Things that would prevent us from using this tool are if you do have the BRCA1 or BRCA2 mutation, if you have a previous history of invasive or the precancerous state of breast cancer, and then other subgroups. So there's some things that don't allow us to use the screening tool, and that puts you already at higher risk. But for the majority of people, we're able to kind of go through this calculator with people. In 2019, the United Services Preventative Task Force actually made a pretty strong recommendation for us to be screening women over the age of 35 for their breast cancer risk, and to use, which I'm going to talk about in just a second, the risk-reducing medications for this indication. So we are trying to be more aggressive about preventing breast cancer in the last few years. So using any medication to reduce risk, we call chemoprophylaxis, chemo being medication or drug, and prophylaxis meaning like prevention. So usually we use a cutoff of 1.7%, which is, if you were in a group of 100 people, 1.7 women out of the 100 would develop breast cancer over the next 5 years. So it's a pretty small percentage, but it is an elevated risk compared to the general population. General population risk is usually around 0.6, over the next 5 years. Medications that can be used are, one of them is called tamoxifen, and the other one is called raloxifene. These are both selective estrogen reuptake modulators, which basically means it reduces estrogen in one place in the body and sometimes it can make estrogen be higher in another place. For instance, tamoxifen is used actually for the treatment of estrogen sensitive breast cancer. This medication reduces the amount of estrogen in the breast and actually increases the amount of estrogen in the uterus. And so this is a medication we typically don't use for women that have a uterus, just because it does increase the risk of endometrial cancer over time. Raloxifene is typically used for women that still have their uterus. It's also used to help strengthen bones and to prevent osteoporosis. And so they're sometimes used for different indications as well. All of these medications do have side effects and risk factors. So tamoxifen and raloxifene do carry a slightly increased risk of blood clots. And so we do make sure that we're really vigilant about that for people. And then the other class of medications that we can use are called aromatase inhibitors. These are often also used for treatment of breast cancer after somebody might have had like a mass removed or something like that. But we only use these medications in women that have completed menopause. They're just not, we don't find them to be effective at preventing breast cancers in younger women. And so we don't use them there. And they, what these medications do is they block estrogen. And so women that still have some of their ovarian hormones in circulation, if you were to give them an aromatase inhibitor, they would feel quite bad, because they haven't gone through menopause, and they're still used to having all those hormones in their bodies. So this is a very nuanced, detailed conversation. If you're interested or feel that you are at higher risk of breast cancer, that you should have with your doctor to see, where you fit within this schema. The one thing I also wanted to mention is, so how much do these medications actually reduce your risk? And so the data that we have showed that they reduce the risk of about 40%. So for instance, if you were this person that just was over the cutoff of the 1.7% increased risk over the next 5 years, it would really only bring down your risk to just under 1%. So you really have to discuss with your doctor if it's worth it for you to be put on one of these medications, if it's going to really reduce your risk enough, and how important that is to you. So I think having a personalized conversation is very important before really undertaking these types of medicines. For certain women with the the BRCA mutations, they will elect to proceed with the risk reducing surgery. So that is also a very nuanced conversation to have. Anyone that does have those mutations should have a consultation with genetics, just to go through their risk and the future risk for other family members, to do their family tree and kind of go through everything with that, so that they have a good understanding of how to handle and to understand their options in terms of prevention and treatment should a cancer arise. I also just wanted to say, so there is a wonderful program in New Jersey, just to kind of sum up the last point, that if you know someone that is under insured or uninsured in New Jersey, there's a program so that you can get preventative cancer screenings for free. So Cooper and Inspira are New Jersey seed sites. I put the number on the screen just so we can make sure that everybody that wants to be screened for cancer can be screened. They not only do provide mammography, also pap smears and colorectal cancer screening. So it's a really wonderful service to our state and for people that aren't able to get those screenings otherwise. Some final takeaways. That breast cancer is very prevalent and is one of the leading causes of cancer mortality among women. There are definitely some things that we can do to stay on top of this, but and can reduce risk. But if you are at elevated risk, there are steps you can take to reduce that. But it does take a very nuanced conversation with your doctor. And that's all I have.
Thank you, Dr. Hussain. all is an understatement. You had a lot to offer to us today. So I know that you received a question, and Dr. Schmutz, you received a question as well from the audience. So why don't we have some answers to those questions, and then we can see if there's more from the participants that we have.
Oh, okay. So
The question that you posed to us this morning?
oh, sure.
Oh, the one I see a question in the Q&A for me. Should I answer
Okay.
that one?
Sure.
Okay. So the question is for everyone who may or may not see it is, do you think there should be a reevaluation of the diagnostic criteria for PMDD to decrease the number of symptoms required, considering that up to 35% of the population can be considered subclinical? So I mean, with the DSM, I do find that there are some diagnoses. I mean, actually, all of them that have a cutoff, which all of them do, can be restrictive. So, I mean, I think if you see a good psychiatrist or someone that specializes in women's health, they don't really I don't really care whether you have 3, 4, or 5. Like, if you're having severe symptoms and it causes you major dysfunction, that's sort of where I tailor the diagnosis. That being said, the DSM is being revised currently, and there may be a new edition that comes out within the next few years. And so it would be interesting to see if they have less restrictive criteria for PMDD. So I use the diagnostic criteria as a guide, and I use my clinical acumen as the sort of my, where I end. And then, I mean, where it has the most relevance as far as the revision and making it less restrictive is in research and finding, what the real prevalences of certain diseases are. So do I think it should be less restrictive? Maybe a little bit, but also I think there's still this art of medicine and connecting with the person rather than the data. And so if you have a good doctor, I think they'll be able to understand that the criteria are not perfect. Hope that answered your question.
Rachel, a question that I have, you mentioned that there can be a relationship between PMDD and perhaps perinatal depression. Do you watch patients who are pregnant more closely if they have this diagnosis?
I do, actually. Yes, I do. So for patients that have PMDD, if they do become pregnant and they're in my care already at that point, they do consider them as having a higher than general population risk for a perinatal mood disorder. And yes, I do monitor them very closely. If I'm seeing a pregnant patient for the first time, I do a very thorough history on their menstruation and their perimenstrual mood. To determine whether they may have underlying PMDD that hasn't been diagnosed yet. So knowing that, I do monitor more closely during pregnancy, and then if they're pregnant, I do a very thorough history on their menstrual cycles.
Okay, great, thank you. I see a question, Susanna. Did you see the question in the Q&A?
Yes.
Okay.
The question was that you didn't miss the explanation because I did not explain it. But the question was, could you please explain why not having children and not breastfeeding can increase the risk of someone developing breast cancer? And the overall theory is the more menstrual cycles that you're exposed to over your lifetime, so either like going through starting your menses early and having menopause late, and then not having a disruption in the menstrual cycles for pregnancy or breastfeeding, that can lead to higher levels of hormones or like more hormone cumulatively over time, and that can increase the risk of breast cancer. The breastfeeding part, like it sometimes delays the onset of menstruation after a pregnancy, and so it just really it does reduce the amount of like cycles that a person goes through their life if they are able to sustain breastfeeding for a certain amount of time.
Great. Question. I'm a woman that has not had a mammogram yet, and I see the advertisements. It's Pink Month. What do you recommend if I've never had a mammogram? When should I be asking my doctor to get one?
So a lot of societies recommend annually. The American Academy of Family Doctors actually recommends every 2 years, and we're kind of going to every 2 years if you're at average risk. If you're at increased risk, you should definitely get it every year. And increased risk, like first degree family member having breast cancer, you should start at 40 every year. If you're at average risk, you can delay this to 50 and every other year.
Thank you. We have a lot of people who joined us today. Are there any other questions that our participants might want to put into the Q&A? We have a few more minutes. Rachel, you had said something about if the medications don't work, what would be the one or two things that I can do to try to keep my mood upbeat and good during this time? What works for
So
that?
I would say my answer to that is that the medications, the SSRIs in particular, work very well in general, but there are people that can't tolerate them. And there's, for genetic reasons and various other reasons, that there is testing for, actually, that it's called pharmacogenomic testing, that we can determine genetically, at least, why someone may not be able to tolerate an SSRI. And so sometimes what we do, and this is pretty much consensus among other women's mental health providers, is we just try to make you comfortable. And we try to, in addition to the lifestyle changes and the supplements that I recommended, sometimes we just say, what's your biggest symptom? What's hurting you the most? What's bothering you the most? And we try to find a medication that you might be able to tolerate that treats you symptomatically. So I have had patients where they can't tolerate, or they're one of these genetically predisposed to not actually respond well to the SSRIs. So sometimes I delve into other drug classes in low doses, particularly atypical antipsychotics, which are not just antipsychotics. We use them for mood stabilization, for irritability, for sleep, for anxiety. And sometimes on occasion, the benzodiazepines, which have some risk for tolerance and withdrawal and some addictive potential, but in low doses intermittently, especially just during the premenstrual time as needed, can be very, very helpful for irritability and for sleep. So we call those second or third line approaches, but just because you don't respond to first line, or you can't tolerate the first line approaches, there are things that we can do to help to make you feel better. I actually have a person right now with very severe PMDD who's doing very well on a medication called Abilify and nothing else. We tried the other things, they didn't work. She couldn't tolerate them. We got to this one and she's in complete remission. So everybody's different. So similar to what we do with guidelines, if something doesn't work, we change tacks and we try to make you feel, we listen, we identify what your major problem areas are, and we try to tailor the treatment to that.
So you're pretty much saying that I don't have to suffer in silence, that if I've not spoken to my healthcare provider, I need to, and if need be, get a referral to a mental health physician who can guide me.
Absolutely. And there are a lot of mental illnesses out there that are difficult to treat, but PMDD is actually one of the ones that responds best to intervention. So you don't have to suffer. You don't. You have to find someone that's going to listen to you, knows what they're doing, and you can feel better.
Someone like you. Do we have anything else from the audience? Well, if not, I'm going to give you back 10 minutes to your day. I want to thank you very much. We had a great participation. I know our speakers are top-notch. They know their material well. And I want to thank you. We will be resuming our program once a month now. We have some great topics slated from now through, I believe we're into April. So watch for the emails, and we'll see you again. Thank you very much. So long.
Thank you.